Any questions that have come up so far from the audience? Please come up to the microphone. We have a few cases to go over, but they're more, discussion points. So if you have any questions to discuss, we should go ahead and do so now. Anything from the panel any questions that have come up? Very well. So let's go ahead with a case. Let me get the big screen here. So a 65-year-old white male with a history of STEMI after PCI 6 months ago comes in to see you for follow-up. He's still smoking, and he's taking his meds as prescribed. He exercises regularly, his blood pressure is well controlled, and his BMI is 24. He's on rosuvastatin 40 milligrams, but his LDL is still 132, his HDL is 32, and triglycerides are 125. Should you add more medications to his regimen of aspirin, beta blocker, statin, nitrate, diuretic, and ACE in order to get his lipid profile in better standing? And if so, which of these would you do? I'll open it up to Dr. Belagati.
Yes, I think, this residual LDL is still 132. Patients who have recent acute coronary syndrome with a high residual LDL on maximal statin continue to have high levels of events. So we definitely cannot let him ride. Basing on the IMPROVE-IT trial and cost considerations, I think this is the kind of person I would still add the ezetimibe first. One can argue that the amount of reduction he may get from ezetimibe may not get him all the way down to the level we want, since we are starting at 132. But I think that would still be, the prudent course to start with.
Okay, other points of view? I mean, obviously, some of us might want to do all of the above, but...
Well, I would tell you that I would look for anything that would point me toward polyvascular disease, and if that is true, then I would actually go to a PCSK9 inhibition, because this is a guy with a very high risk. This is not someone with well-controlled secondary prevention markers. And I think that the PAD data and the polyvascular data pushes me slightly towards being more aggressive with this. I hope my colleague agrees, but if cost is not a consideration, I think I would actually push on with actually more aggressive therapy with PCSK9.
Yeah, I mean, I agree. I think we're also saying similar thing. We think we're going to get there, that we're going to need more than the ezetimibe, given that very high, and presuming if that was the LDL on the high intensity statin, you presume that it was, in FH levels before, if it's here, and so you probably are going to need more.
Right. So what about the HDL portion? I mean, can we raise HDL safely and effectively yet?
No.
Yeah, agreed.
The answer is no.
The short answer, unfortunately, is no. But smoking cessation, we know, will raise the HDL, so that would be our main focus. But yeah, I think the answer, based on our presentations, is that the Zetia certainly would be added as but probably not sufficient, given that the average lowering was only 16, and you'd still be in the above 100 range and certainly above 70. And the question would be, can you add a PSK9 inhibitor? Would it be cost effective in this patient? Well, the answer is probably yes, right? Because he's already declared himself to be a vasculopath with a STEMI, and he is probably going to be benefited by that addition. So this is that patient right here in the secondary prevention guidelines from last October 2018. He's a very high-risk patient, already on a maximal or high-intensity statin. Adding a Zetia is reasonable, class 2A, and then if his LDL is still above 70, the guidelines now say it's class 2A to consider a PSK9 inhibitor, just to reiterate that. So the next question for the audience and also for the panel is, which of the following patients should be considered for a PSK9 inhibitor, such as evolocumab? A 90-year-old patient with CAD with prior MI, LDL 140, still on a high-dose statin. B, a 60-year-old man with ischemic cardiomyopathy, EF 20% with LDL 60 on atorva 80. Or C, a 30-year-old man with heterozygous FH, LDL 140 on atorva 80 and Zetia 10. Dr. Hamburg, lead off.
Well, I think you're trying to get us to think about sort of the overall net clinical benefit for patients. I think certainly if you look at the last patient there, again, to me that brings in this whole question of primary versus secondary prevention in FH. So I think there you clearly, you still have high LDL, and even though this person is young, and doesn't have clinical disease, I think we have good evidence that they're going to get benefit for more intensive LDL lowering, and there's no real reason to wait. You're just waiting for them to have an event. It would be better to do it before. The other patients, I mean, I think in 90-year-old patients, I mean, I'm really thinking about sort of what are the overall benefits of their polypharmacy versus sort of quality of life benefits. So by the numbers, potentially yes, but I think you have to look at the overall patient to decide whether that really made sense, not just from a cost perspective, but from a taking care of that individual patient perspective. And the middle patient, I don't think we have any specific evidence about patients with myopathy and PCSK9 unless someone else knows.
6 months survival is very poor of this patient.
Right.
Aggressive cholesterol lowering may not be the answer.
Actually, both the PCSK9 trials excluded patients with low EF.
Yeah.
So Fourier had a cutoff of 30 or class 3, class 4 heart failure symptoms. Odyssey had a cutoff of 25 or class 3, class 4 symptoms. So this was not even a studied population. And if you believe in GCHF and corona, turns out cardiomyopathy patients actually don't get that much benefit from. So B, I would say definitely no. C, I think, is where the money is on top of 80 and 10. I think the guidelines still recommend that stepwise approach, and on that approach, he's still 140, and he's at very high lifetime risk of events. So I agree with Dr. Hamburger. C would be the value proposition.
Thank you very much. These are always designed to be outside the guidelines, right? So this is the discussion point, and I thank you for pointing out the Corona study, which showed that in cardiomyopathy patients, not even statins showed a benefit. So even though in the guidelines these people have a low EF, they are at risk for more events, we haven't really proven that it makes a difference to lower their LDL. And then the 90-year-old patient, obviously there's other comorbidities that will likely be around that may make it less cost-effective. Surprisingly, though, this 30-year-old patient with no cardiac event yet with FH is not studied adequately. It's only a 2B recommendation, and so that's still a question mark, surprisingly.
If you remove the word heterozygous, it might become more strong.
Yes. Anyone with homozygous FH should certainly be on.
I just want to point that out.
Thank you.
The word heterozygous is not missed by the audience. So.
Right. Very good. So it's 8 o'clock at this point. I thank the audience for their attention and the panel for their excellent perspectives. We're available for any questions afterwards, and I hope you have a good day.
Thank you very much. Thank you. Thank you.